Welcome back to the Girlfriend Doctor Show. Heart disease in women. What are the early signs of heart disease in women? Many women in perimenopause may experience heart palpitations, and this creates a crisis and a visit to the um, ER, emergency room, or doctor's office. What are some of the signs related to hormone imbalance that affect our heart or symptoms of a heart? We know in men, erectile dysfunction is a symptom of heart disease, even if it's in your 30s or 40s, that we need to check these things out. And it's so critically important. And especially in women, cardiovascular disease is called a silent killer, and it is the number one cause of death in women. So some of the symptoms can be hot flashes. Women with hot flashes, it's associated with a higher risk of heart disease. And then there's the question about hormones. Do we or do we not hormones? So what's the relationship of hormones and heart disease? We're going to talk about that today. So cardiovascular health and menopause, hormones and heart disease, metabolic health and weight management, stress, sleep, and heart health with my guest today, who is an accomplished cardiologist and vice president of medical affairs for Hello Heart, where she has a focus on women's health and AI. This is Dr. Jayne Morgan. I'm so excited to introduce you to her today. She's been a voice, a very outspoken and loud and proud voice for women and heart disease early diagnosis and prevention. So I'm excited to interview her today on our podcast because you guys have been asking, what about heart disease? What are things we should know? What should we test for? And we're going to touch on those topics today. Dr. Jayne Morgan, has an extensive background in clinical trials and cardiac research. She's made significant contributions to patient care and medical advancement throughout her career. Her expertise encompasses not only the assessment and treatment of various cardiac conditions, including heart disease, arrhythmias, and heart failure, but she's also highly regarded for exceptional skills in the interpretation of complex medical data. She's currently in Atlanta, Georgia. She's also founder of the Stairwell Chronicles, which provides up-to-date medical and scientific information in an easily understandable format. And I'm super excited to introduce her today and share her amazing knowledge and breadth of research with you. Well, welcome, Dr. Jayne Morgan, to the Girlfriend Doctor Show. It is so good to have you here and to talk about such an important issue of cardiovascular health and menopause.
Yeah, I'm so happy to be here, Anna. It's, near and dear to my heart, and I am happy to continue to talk about it, continue to educate people.
Well, that is, I feel like you are one of the voices, one of the few voices talking about menopause and the cardiovascular risk. And as we were chatting before you got started, it's like the number one killer. And so, how are you so passionate about this, especially in menopause? And what has brought you to this place where you're so like vocal about it? I mean, so your voice that needs to be heard. That's why.
Throughout my career, I increasingly became interested in women's health. And actually, it was during COVID when I started to notice differences and notice changes. And I was doing a lot of media, and other people were starting to do a lot of social media as well. That I started to become increasingly drawn into this space of menopause. One of the reasons is that I began to recognize that the connection of estrogen to heart disease. And of course, as a cardiologist, I was very much aware that heart disease was the number one killer of women, but most people, even physicians, were not aware of that. And even a lot of the physicians that I was seeing in media and social media were very focused on sort of the reproduction aspects of women's health. And nobody was really talking about the heart. And so I just started having these conversations, actually first with Dr. Sharon Malone on a My Alloy podcast I went on. And we just started talking about it. And I began to talk about the connection of the heart to estrogen. And from there, I began to develop keynote addresses and speak about it and make certain that people understand that the symptoms of menopause are not innocuous, They are symptomatic of decreasing estrogen levels, and decreasing estrogen levels really increase your risk of heart disease because estrogen is an anti-inflammatory agent. And estrogen also has a direct cardioprotective effect on the heart. And so all of these symptoms in perimenopause and menopause are actually biomarkers for heart disease and biomarkers for stroke. And that's actually how we should look at all of these symptoms, including hot flashes, night flushes, palpitations, itchy ears, all of these things. They are actually risk factors for heart disease. And imagine trying to get doctors to now think about that. A patient comes in and says, "Oh, I have itchy ears." They need to think, "Hey, I need to be concerned about their heart." But they should be connecting those dots. If you have a woman within a certain age range and they're coming in complaining of any myriad of symptoms of perimenopause, 35 to 45 to 55, depending on how you're counting, symptoms of perimenopause that seem completely unrelated to heart disease, we need to start thinking about heart disease.
Well, I think it's so important. For example, the symptom of palpitations that in perimenopause or early menopause takes a woman into the ER. How
Right.
should she, like when she's feeling those palpitations, think it's the heart disease, where can you address that? Because it is a very common symptom. We
It
get
is.
like full cardiac workups and then the hormonal components of that.
Right. And certainly heart disease is the number one killer of women. So I don't advocate for you bypassing your cardiac workup if you're having palpitations, because you could be having palpitations because of undiagnosed and undisclosed heart disease, including microvascular heart disease that's more common in women. So I'm certainly not advocating for skipping the ER and going, "Oh, this is all my hormones. I'll just stay home, or I'll take some estrogen." But what I do want you to understand is that if you're within a certain age range, let's say between 35 and 55, then there is a high probability that your palpitations are related to have an inverse relationship to your estrogen levels. So as your estrogen levels drop, your risk of developing palpitations increases. Remember, I told you that estrogen receptors are on the heart. And
Mhm.
so now you have less and less estrogen binding to those receptors. Again, I want to be clear, heart disease is the number one killer of women. And you, as a patient or a member of the public, do not have the ability to discern whether your palpitations that you're having at home are related to your perimenopause or are related to a real heart issue that could pose an impending heart attack. So I do want you to seek medical care. That cardiac workup is important, but then also make certain that once that cardiac workup is negative, that you are thinking and continuing to push your doctor to give you answers. And here's usually sort of a garbage can diagnosis. "Oh, we found mitral valve prolapse," right? So many women have mitral valve prolapse. It's just a small degree of insufficiency in the mitral valve. It is a garbage can diagnosis generally that's more often given to women and then attributed to a myriad of other things: anxiety, panic attacks. For the rest of your life, when you see your cardiologist, when you see your primary care physician, you have symptoms. It's like, "Oh, that's your mitral valve prolapse." So if your mitral valve prolapse is mild, they use that word mild, that is not the reason for your palpitations. So I want you to make certain if you're in midlife that if your cardiac workup is negative, including just a mild insufficiency of the mitral valve, that you may then seek higher information regarding menopause from maybe a menopause specialist, or even your physician may have that information, because you have the right to have the discussion about hormone replacement therapy. It's not the right choice for everyone, but you should have the privilege of having that discussion with your physician.
Well, and let's talk about what constitutes an adequate or thorough cardiac workup.
So that is very individualized, and it will depend on your presenting symptoms, your past medical history, your lab work, your family history. So that's very, very individualized. At a high level, you will get an EKG. They may get an echo, which is an ultrasound of your heart. You might have a stress test. Those kinds of things are just basics, but going on to more advanced cardiac workup, that really is going to depend on the results of some of the early tests. And also, again, what your presenting symptoms are. What else are you experiencing besides the palpitation? So a careful history would be taken, and that would really determine the course.
And what about a CT calcium score or the Clearly evaluation?
Yeah. So
When
a
do you
calcium
recommend
score,
those?
yeah, a calcium score is generally used. People often asked about a calcium score, and they think that a calcium score really determines what other tests you're going to take. It doesn't. A calcium score actually is used as a guide for what your 10-year risk is of a heart attack or heart disease. And generally, it is given in women who are asymptomatic. Once you are having symptoms, generally a calcium score is not that helpful because we're moving on to more diagnostic tests that drive therapy. Calcium scores do not drive therapy, they drive recommendations and guidance. So in asymptomatic, we're talking about women, so I'll just talk about women, but this is for men as well. People who are asymptomatic, you can have a calcium score such that you and your physician can sit down and determine based on your score what your 10-year risk is of heart disease and whether or not you and your physician should decide in a shared decision-making conversation what steps should be taken further for prevention in you. Prevention of heart disease. And it's one of the things that the medical system here in the US doesn't do that well. We really don't practice prevention that well. We are an intervention treatment system. We are good at that. We are
Amen,
good at
amen, right?
treating and intervening. We are not as great at prevention and keeping you there in the first place. So something else I talk about.
I think that is so critical. That is so critical. And when we talk about prevention of heart disease,
Mhm.
let's talk about some of those things, some of the steps that women can take. I definitely address that. Before we move away from testing, what about the fractionated cholesterol patterns and looking at pattern A and LPA and ApoB
Mhm.
and LPIR levels or insulin resistance markers? What's the role of that, and when should we look at that? What age should we look at that,
Yeah,
if at
I mean,
all?
I think it's important, to get a panel, especially looking at insulin resistance, LP little a. I'm on the steering committee of Novartis of the Heritage and Horizon trials developing drug therapy for LP little a. So stay tuned for 2026. If you don't know what LP little a is, it is a type of cholesterol. It's sort of another of those bad cholesterols like LDL. So I'm using that word. I hate to use bad and good, but just to simplify it, it uh, greatly accelerates your risk of heart disease and early heart disease if you have a high enough score. So generally that score is over 30 for your LP little a. Um, we see that oftentimes because it has a genetic component in African Americans and also Southeast Asians, but it's also seen in whites, albeit to a lesser degree. So how would you think to test your LP little a? If you have a family history of family members who maybe have had a sudden death before the age of 50, you don't really know why they died. Uncle Bill, collapsed, or someone died in their sleep, or, sort of unexplained deaths in people under the age of 50 in your family. Oftentimes you'll hear people talking about, oh, you remember he just fell in the street and he died and that sort of thing, or he just didn't wake up. Those are the little things you need to probably keep your antennas up for. You maybe need to look at LP little a, get those values drawn. If your value is elevated, also contact, and your physician should be talking with you about it, your family members, because remember I told you it's familial, it's genetic, to have them be tested as well. So what can you do while we're waiting on therapy? One of the reasons that doctors have not tested routinely for LP little a, here's a little secret of our community. We don't really like testing for things that we don't have a treatment for. So there's a little secret. All doctors know about it. There's no therapy for it. Why are we going to treat for it? But here's why that thinking is changing. we know that if a patient now has an elevated LP little a, we can be very, very, very aggressive in managing all of these other risk factors for prevention, including an LDL level now that needs to be even lower than 100, it needs to be down less than 55, a blood pressure that cannot be allowed to hang out even at 130 over 80. It needs to be 120 over 80. We know that that patient has really got to take exercise seriously and making sure their body is moving. If they're smoking, they've got to quit yesterday. So we can be incredibly more intense with our recommendations and also set the bar higher for where we are going to have cutoff goals for things like cholesterol and blood pressure, and then that insulin resistance, tight control and follow up of your glucose. So all of those things we can do, and we now start to understand that, including trying to reduce chronic inflammation in your body. Food is medicine, and addressing your diet seriously and making certain that you understand the connection between, inflammatory processes and heart disease. So now we know, as a physician and also other clinicians and healthcare workers, we have a unique position to influence that patient and influence the outcome. And even though there is not a treatment, meaning a medication or injectable available to treat LP little a, we can aggressively work to lower and modify the risk factors in that patient for heart disease, including, like I said, including managing that cholesterol. If you're not on medications, take your medications. And the number one thing that I hear people say, maybe not the number one, maybe number two or three, but I hear it often, is they don't want to take medications. And I'm going to do it the natural way. And, here's what the thought used to be when I was in training, that if you have a patient and they have high blood pressure, they've got high cholesterol, and they have, mildly elevated glucose for diabetes, and they're overweight, you can give them 6 months to sort of try diet and exercise. And then you sort of bring them back in 6 months to see if they've shown any improvement. And then sort of second line would be to start medications, give them an opportunity to kind of manage it themselves. Well, here we know that even in a 10 millimeter increase in your systolic blood pressure increases your risk of heart disease by 20%. So we don't really ascribe to that anymore. We would like to get you to goal immediately. Then you still go and exercise and you lose weight and you monitor your eating. And when you come back in 6 months, if you've gotten better, we are happy to dial back those medications. But
Or
we
stop them
want,
completely, right? If
that's
they're
right. We want you to be at goal. We now know it is a risk to allow you to kind of just hang out for these periods of time, 6 months, 8 months. So I will stop talking now, but
Yeah,
that's all.
no, that's so good. It's so good.
Yeah.
Sometimes the question and concern is, like, cholesterol is the precursor for progesterone and pregnenolone, and from there we make our sex steroids, DHEA, testosterone, and estrogen. And the cardiologist, Dr. Canonico, in Italy, I think it was 2017, published on the cholesterol lowering agent, so statin medications causing hypogonadism in a study of 3,000 men compared to placebo. So what's the role then of our hormonal management if we're driving cholesterol that low?
And I'm sorry, you would have to repeat the last part of
Oh,
that.
oh,
That
sorry
the
about
doctor,
that.
yeah.
So yeah, in the research with Dr. Canonico looked at 3,000 men on
Okay.
and studied men on statin medications, and
Mhm.
it showed significantly reduced testosterone levels.
Okay.
And so when we
Oh, I
think
see,
of
on statins. Okay, that's the
on
part that I didn't hear. Okay.
on statin medications and lowering driving that cholesterol down
Mhm.
so low, what then happens, because it's driving our reproductive hormones down? So how do you approach, or how should we make sure that we're optimizing hormonal therapy in those patients, and what considerations are there?
Okay, so I'm not familiar with that study, and because it's all men, I certainly
Yeah.
would like to see studies in women so we can
So
stop
would I. So would I.
extrapolating data from men to women and just kind of pasting it on there. So here's what I would say. Cholesterol and estrogen share a common metabolic pathway in the liver. And, statins, have, come in and out of favor. But the fact of the matter is, when we look at statin therapy in women, it does decrease LDL. It raises HDL, which is which is the good cholesterol. It also lowers LP little a. It is the only therapeutic that we know of now that actually does lower LP little a. And why is that important? LP little a, I'm going to go back to that, is a value that generally is tested only once in your lifetime because it's
And
thought
what
that it
number
is
do we want it to be
at 30 or less.
30 or less. Okay.
So LP little a is a value that is tested only once in a lifetime. So that's the current thought because it doesn't move much. But we see with statin therapies, it actually does move a little bit. And so the question is, again, this study on men, good for them. The question is, with estrogen and hormone replacement therapy, can we continue to push the LP little a down further? And if we do, does that confer a change in risk or it does not? So how valuable is that number? Those are the answers that we don't know the answer to, right? Because we're not doing research on women. We're not doing clinical trials on women. And it looks like with this current administration, we'll be doing even less than what we are so far. So we just don't have those answers. Estrogen, estradiol, transdermal, and even to some degree, vaginal estrogen has been shown to lower cholesterol. And so these are all, things to kind of consider. Again, every woman deserves to have this conversation with their physician regarding what these options are. I hear people talking about natural ways to lower your cholesterol. So, for instance, red yeast
Yeast
rice,
rice. Yeah.
red yeast rice, and there is some data that does show that it lowers LDL. I don't know if it is legally available here in the United States because it does contain the same active ingredient as a statin, actually. And so that does make you think, it must be working. But because it's got that active ingredient in it, it is difficult. The FDA has not approved it to be here in the United States. So I see people bringing it in from other countries and that sort of thing. But, I'm not against supplements. I see people doing these different things. What I always say is I'm not against it. And I'm not saying it does or doesn't work. I'm just saying we don't have data
Yeah.
that can support whether it does or doesn't work. We just have testimony in you, a single patient. You took red yeast rice and your LDL dropped by 20. That's just a single case report. So that's what I try to explain to patients. And unfortunately, we're in this sort of vortex of no information on women. And so then we have to do our best looking at observational data on women, retrospective data on women, knowledge that we have on estrogens and statins and progesterone and menopause and heart disease, and connect the dots until we can get this real evidence-based medicine randomized clinical trials. Now, that's not to say we don't have randomized clinical trials. We certainly do. There are several. And I actually quote them often, but they are few and far between, and we don't have any that are super recent, and we certainly don't have the plethora of information that I would like for us to have.
Yeah, I know as you were talking about little LP little a, I have to admit that I had to look up my labs, and the lab says LP little a less than 75 is normal, and you're saying less than 30.
So
And I'm
it
like, okay,
depends on
mine's
what is the
the
measurement. So it's the lab measurement.
nanomoles per liter.
Yeah.
So yeah, so mine's 47. I was like, okay, maybe I need to drive that down a little bit more. But it says less than 75. But do we
So
really
maybe
need?
that's with the nanomoles, right?
Okay, yeah, that's the one it gives. Okay, so
Mhm.
something to consider, a strong family history of heart disease. And I think, for me, I'm first generation American, dad's Portuguese, mom was Palestinian, and data on white men in heart studies doesn't pertain to me. I lost my mom at age 67. When she was 67, I was 30, and due to heart disease and cardiac, undergoing a second cardiac surgery. So I pay attention to this and the ethnic varieties and what these studies say. And I love when you talk about this specific area, because we're not all the same. We shouldn't be treated like the same. And so the
Right.
considerations, and one of the other things that you talk about is pregnancy being a stress test. and
Mhm.
I want to draw those lines too.
I do talk about that. I used to talk about that a long time ago, years about, with medical associations about pregnancy being a stress test. And I hear more and more people saying it now. So I'm actually wondering, did I coin that phrase? Where
You
did that?
totally coined it. I'm
Because
sure you
I
did. That is
said
so
that all
good.
the time and I never heard it before. Now I hear people saying it. It's like, I think people are listening to me. I think people
Yes.
have heard me say it. But
It's such a good point. Yeah.
yeah, here's the deal. Pregnancy, and I'm so happy that people are listening and paying attention, because it's really good information. And so when we talk about women's health, which is one of the areas that I'm really focused on, and connecting it to heart disease, here you're probably thinking, why is a cardiologist talking about pregnancy now? Why is a cardiologist talking about menopause? Because it's heart disease, and here's why. When we look at pregnancies, when we look at complications of pregnancies and our high maternal mortality rate in this country, and complications of pregnancies are anywhere between 7 to 13%. And when we talk about complications, I'm talking about things like high blood pressure or hypertension, or a low birth weight baby, or gestational diabetes, meaning diabetes during your pregnancy, or preeclampsia or eclampsia, or even an older term, toxemia. If you've ever heard any of those terms or suffered with that during your pregnancy, or had a high risk OB managing you, then I'm talking about you, because here's why it's important to have different lenses on different problems. It's why it's important to have teams of people who see things from different perspectives. So the classic management of these patients is to have them on a high risk OB/GYN team, and then to get that woman to delivery safely. And once that baby is delivered safely, everyone breathes a sigh of relief, and it's been a big save, because we know that once the baby is delivered, a lot of those indices that we have been managing and following return to normal over time. So the gestational diabetes regresses, the blood pressure regresses. This is just in general at a high level. So the aim was really just to get the woman to deliver that baby safely. And then everybody just applauded, and we applauded ourselves for getting someone through a difficult pregnancy. Here's why it's important to have diversity of thought. So now we understand it's important to have a cardiologist on this team, and we're starting to build these cardio OB units. Why is that? Because an OB/GYN, even a high risk OB, looks at this patient and says, I have a 34-year-old female in her whatever 32nd week of gestation with a diagnosis of preeclampsia. A cardiologist comes in and says, same patient, and says, I have a 34-year-old female in volume overload who's just failed her stress test. Same patient, two lenses looking at the same patient. Now, the assessment of the cardiologist takes the workup of that patient and the management in a different direction when you understand that it's volume overload and it's a failed stress test. Like any person who fails their stress test, they go on immediately to a cardiology referral and a high level cardiac workup. That doesn't happen in this patient because we don't have a multidisciplinary team, and there's never been another lens to look at it. The same patient, you're looking at now a different organ system from a different perspective and a different level of training and experience. So the other thing is, if you've had any of those complications, your long-term risk of heart disease, that is a marker, another marker. Your long-term risk of heart disease will be at least twice that of a woman who's not suffered those complications. And that's long-term risk. And then think about entering perimenopause and menopause later, where your estrogen levels are dropping, and your risk is even further compounding on the risk that you didn't know you had from the pregnancy, because nobody told you, nobody gave you a handoff to a cardiologist, and the cardiologist was not a part of your team, and everybody thinks you're fine. And we see maternal mortality rates increasing, and it just goes on and on and on and on. So I'm working to try to, can we dial this back and unravel it? And not a lot, but there are a few centers who now have begun to open cardiac OB units or OB cardio units, because they understand now, finally, that a cardiologist has got to be a part of this team. Because yes, we still need to make certain that we deliver this baby safely and we manage this mother safely, but we also know that this is a marker for heart disease, and a cardiologist must be involved.
And I think that's so important, like twice the risk, right? And same
Right.
with the gestational diabetes and the relationship. Can you speak to the relationship between diabetes and cardiovascular disease? Because we know that our risk, if we have diabetes, our risk of cardiovascular disease is exponentially more.
Arguably, diabetes may be the number one risk factor for heart disease. I kind of go back and forth. Sometimes I say high blood pressure, but it still may be diabetes. Diabetes may still be edging out blood pressure. Blood pressures are close too,
Or
but
insulin resistance. I
yeah,
would even dial it into insulin resistant
that's
is
right.
a significant risk factor for
That's right. And
cardiovascular disease.
diabetes is, we used to call it cardiovascular equivalent, and it accelerates the development of atherosclerosis in the arteries of your heart. So in other words, it accelerates the creation of plaque buildup in your hearts. And it's those plaques that increase your risk of heart attack in any number of ways. One, they can become big enough that it actually block the artery and the flow of blood. And you don't have oxygen now going to the heart, and that part of your heart will die. That's the heart attack when you start to have cardiac symptoms. And we can talk about even cardiac symptoms and what that means in women, if we have time, or I can come back on another day. So I'm just going to stick onto this topic for 1 second. The other way a plaque can induce a heart attack is it can rupture. These plaques can be unstable and actually rupture, and also then cause a heart attack. So diabetes accelerates the development of all of these plaques that are that that are the reason for the blockages of arteries that are feeding oxygen to the heart. And here's something else that I talk about, just another topic, but I'm just going to touch on it just slightly before we leave, is that what's happening in your coronary arteries, meaning the arteries of your heart, are also happening in the arteries that are feeding your brain. So the brain and the heart are really, really connected. And it's not by happenstance or coincidence that many people who have heart disease and heart attacks also develop earlier dementia, or also have a risk of earlier strokes. That's because the two are very related, and those processes that occur in the heart also are occurring in the same arteries that feed the brain. And then when you think about it, the brain sends, I don't know if you think about it, I don't know what the background is, your audience, but the brain sends electrical signals or neurologic signals to the heart. And then the heart responds by squeezing and pumping blood out of the aorta, comes up through these carotid arteries to feed the brain. And the brain has lots of good oxygen and is well fed, so it sends more signals down to the heart. The heart is strong. It pumps again and sends more oxygen to the brain, and it's in that loop. Imagine if the heart has a heart attack and part of it dies. Now it's not squeezing as hard. not as much oxygen is going to the brain. The brain is starting to struggle. It's not being fed the oxygen. So it's sending signals to the heart. Heart's not really responding. You can see how that loop and that cascade uh, starts to sort of devolve as
Evolve,
well.
yeah, to spiral. And what about in the last minute or 2 minutes,
Right.
Jayne? I know you've got clients. So in the last minute, what about if you have been diagnosed with high blood pressure, cholesterol issues?
Oh,
Now,
such a good point.
what about the candidacy for hormonal therapy?
Yeah. Um, if you've been diagnosed with any of those risk factors, you are a candidate. Now, this is at a high level. We need to talk to an individual patient, but risk factors does not obviate you or exclude you from consideration for hormone replacement therapy.
Great.
Established heart disease currently probably does. Now, there are some nuances to that. So, again, have this conversation with your team of physicians, preferably your cardiologist in conjunction with your OBGYN or menopause specialist. But currently, if you have established heart disease, you are, in general, not a candidate for hormone replacement therapy. Risk factors, however, are different. Now, if you're over the age of 60, there's also a little bit of controversy and a nuance and a gray area. Now we're back to sort of my other favorite topic of clinical trials and research and why we need them. But if you're over the age of 60, even if you don't have heart disease and you don't have symptoms and you have some risk factors, the thought is that most people over the age of 60 have some degree of heart disease, whether they know it or not. And therefore, they are considered as a person with established heart disease, even though they may be asymptomatic. And we therefore do not generally, that now this thought is changing, recommend hormone replacement therapy if you are if you're over the age of 60 to start it. Now, if you're already on it, you can continue it. But we're talking about the first time that you start it. These are nuances. It
Yeah,
doesn't mean that is true, right? And so
right.
we've got calcium score we can look at. We've got, CT angiograms. We have a number of things, but just in general, this is the high level thought, and it is changing. I want to be sure. You might have me come back in 6 months and it's moved on to something else. That's why I say have these conversations, talk with your physician about your history, your symptoms, your family, and determine what's the best course for you.
I think that's well said. Everything has to be individualized. And as I let you go, and I really appreciate your time, how does our audience connect with you, get
Oh,
your latest and up to datest information when it comes to women's health and
yes.
cardiovascular health?
Please, you can follow me at Dr. Jayne Morgan, Drjayne. I have a Y in my first name, JayneMorgan on Instagram, on Threads. I'm also on LinkedIn, Dr. Jayne Morgan, TikTok, Threads. I do a lot, though probably mostly on Instagram, but you can find me really everywhere, including YouTube. And what I will say is, even today, I post something called the Stairwell Chronicles, where I sit on my stairs and in 60 seconds or less, I talk about a medical topic that can help you live your best life. Just some information in 60 seconds or less. So it doesn't take up a lot of your time. And actually, today I talked about arm position for measuring your blood pressure, home blood pressure monitoring. And we didn't talk about how important it is to manage your blood pressure today. But as I said, we can't cover everything in one podcast. So every Wednesday, I post those. Last Wednesday, I actually posted part one of the series on blood pressure, just on body positioning and how to lower your blood pressure and breathing and that kind of thing. So if you want to go back to last Wednesday, and then come to this Wednesday, next Wednesday, I'll do part three. But I talk about all kinds of things. But I happen to be talking about the importance of blood pressure today and just simple things. How do I take a blood pressure? Where should my arm be? And what is the position of my arm? I'm talking about that today, 60 seconds or less. So feel free to tune in.
I think all these pearls and again, empowerment pieces make such
Right.
a big difference. Thank you so much, Dr. Jayne Morgan, for
Thank
being with us
you. Yeah,
today.
I love it. Thank you for the invitation.
My pleasure. There's so many key aspects when we're talking about hormonal management and cardiovascular disease in women, that women with diabetes have an increased risk of cardiovascular disease. And even research has shown that women who have had a hysterectomy and have had their, with or without their ovaries removed, have an increased risk of diabetes. And this comes back to the hormonal connection, something I talk about so often, the hormonal hierarchy. So when we look at what the imbalance and what insulin resistance, early signs and symptoms of insulin resistance can be that hot flashes, can be the weight, inability to lose weight, can be dysfunctional bleeding that is part of the reason for the hysterectomy to begin with. And if we don't address that insulin resistance and insulin sensitivity, if we do address it, let's say we could potentially prevent that hysterectomy, but also we're improving and decreasing the risk of cardiovascular disease. So insulin sensitivity, following the keto-green 16 plan. It's the easiest plan I have to follow. And the second thing is coming back from the, Harvard Women's Health and Menopause event. As Dr. Jayne Morgan said, it's like, okay, definitely have the conversations with your doctor about, is it too old to start, et cetera. But there's a lot of proponents for safe transdermal use of hormones, specifically transdermal estrogen, and vaginal DHEA, to help support a woman long term. And I'm an advocate of bioidentical progesterone from perimenopause onward, progesterone and pregnenolone. A lot more research needs to be done in women. That's the bottom line of this. But with what we have, we remember we have to be our best advocates for ourselves. We talked a bit about statins. I do want to remind anyone on a statin medication or on red yeast rice, you need to supplement with CoQ10. CoQ10, 100 milligrams twice a day, and always address the underlying issues that are causing the problems and symptoms. You are your own best advocate. And so knowledge is power and empowerment. So I continue to encourage you on this journey and to listen to your body and always to take your one next right step at a time. This is Dr. Anna Cabeca. Thank you for being here on the Girlfriend Doctor Show. Please continue to send in your questions. That helps me bring targeted guests and answer your questions on the show as well. I appreciate your testimonial so much. Head over to YouTube and follow me at The Girlfriend Doctor, Dr. Anna Cabeca, and subscribe to my YouTube channel. We have a lot of clips, show notes, and bonuses coming up there. So check it out there. Thank you again for being here.
Thanks for watching another episode of the Girlfriend Doctor podcast. Check out all the links below for more.